Good afternoon, everyone. Well, I'm still trying to figure out if there's some attempt to match the music with the personalities of the people on the stage. We're going to have to
do a study.
Maybe we'll look at that at the end of this panel. You can judge. So hi, I'm Tim Ferris. It's a pleasure to be here, and this has been really enjoyable for me to listen to everything. So far today, I would say, particularly the morning session, when I think about the morning session, and here we are getting toward the end, the morning session was very, very specific. We heard some really interesting discussions of very specific applications. We are now going to complete the arc of the journey to the very general, and we've got a terrific panel. I'm going to ask each one of them to introduce themselves, and then I'll do a little setup, and then we'll get into the discussion. So, Nancy, please.
Sure. Good afternoon. I'm Nancy Brown. I'm the Chief Executive Officer of the American Heart Association, this world's largest voluntary health organization fighting cardiovascular diseases, stroke, and promoting brain health and overall well-being.
Hello, everyone. I'm Kris Joshi. I'm the President of the Network Solutions business at Change Healthcare. Change Healthcare, for those of you who don't know us, is the largest healthcare network in the United States. We connect all the different stakeholders across the ecosystem. The transactions that flow over our network represent somewhere north of $1 trillion of healthcare expenditures every year. So we bring a lot of data to the AI party.
Kris.
And I'm the token international representative on the panel. I'm Simon Stevens, the CEO of the National Health Service in England.
Terrific. Well, we have a great panel. I'm going to set up the discussion by giving three specific examples of the use of what I'll label more generally as decision support that I've actually used recently. And they illustrate three different aspects of where we might be and where the policy discussion and the value add discussion might go. And the first is a somewhat nihilistic story of the fact that in my computerized medical record right now, I still cannot get accurate prediction of whether or not the person in front of me needs an immunization. And what's interesting about from a clinician's point of view is you don't have to receive incorrect information more than once to start ignoring that information. Because interestingly enough, while AI and decision support is often probabilistic based, the decisions that face clinicians are rarely probabilistic. You are going to do something or you are not. And so that intersection of how good is good enough and when as a clinician, do you simply say, you know, actually, it needs to be perfect or else I can't really use it? How does that play out in a value equation? The second is an observation about something that occurs over time. So I remember being in the emergency department when the very first computer-read EKGs came out, and I will say it was really easy to beat the computer when the computer was reading the EKGs. In fact, most of the time, the computer got it wrong. I will say in the past decade, I have not seen, in my personal experience as a clinician, an inaccurate computer reading of an EKG. And in fact, as far as I can, they are adding value all the time. They are picking up things that I wouldn't have thought of. And so it's sort of, that was 2 decades of experience over which that change took place. And the third one is I had a patient very recently in which it was breast cancer was diagnosed and treatment started. And I looked at all the different ways AI had been used in the care of this person, and it was rather remarkable. So the mammogram and the reading of the mammogram used AI technology. The pathology used AI technology. The choice of therapeutic plan used AI technology. And remarkably enough, based on this person's demographics and predictions about whether or not she would need assistance adhering to therapy, she got a case manager assigned to her to help with, and a phone-based reminder mechanism to help with making sure she stayed on track with her therapy. So I gave 3 examples, one sort of nihilistic and unfortunate, the other one showing how long this takes to do over time, and the third one like quite transformative, like this person's care was quite different than it would have been just a couple of years ago. So I'm going to use that to tee up a series of questions for this terrific panel, and I'm going to ask each one of them to first respond to your thoughts related to this spectrum of use cases and how those use cases play out in terms of value from your perspective.
Sure. I'm happy to talk about those. I think in listening to all these discussions, one of the things we hope to always do at the American Heart Association is remember that care starts and ends with the patient, and having patient engagement and patient involvement in thinking about how these new innovations can improve value in care delivery for patients is really important. You know, there's no question that people want and expect state-of-the-art treatment. We're the organization with partners that write the clinical practice guidelines for patients in very specific disease areas and broad areas like hypertension and cholesterol. And I think patients would be and are horrified when they realize that it takes 16 years on average for a guideline to be fully implemented into practice. And that shouldn't happen. And so the promise of AI and new technologies to create more efficient ways for clinical delivery is really something that is of high value. And so I think we're quite optimistic at the American Heart Association that the move towards AI is very positive for patients and outcomes of patients, but let's remember what they want at the beginning. And what they want is high quality care. They want more personal interaction with their healthcare provider and less time in the system and more time in their community and with their families that they love.
Great. Kris?
Well, I'll begin by observing that healthcare is a team sport. And when we talk about value-based healthcare, it's even more so. We really expect the healthcare system as patients to work for us. And that means the healthcare system knowing who you are, taking care of you, whether you're in the pharmacy or visiting a friend in another city or going to your local doctor's office. Unfortunately, that level of coordination doesn't exist today. So what we're trying to do with our networks is to put more intelligence in the network so that we can bring both a spatial context about what's going on with the patient, which is knowing what's going on in the pharmacy, correlating it with the doctor's office and the hospital, and also a time view, a time-based view of what's going on with the patient. And those really open up a variety of use cases where machine learning and AI in general can really be very effective, because very often AI is most effective when it's behind the scenes, when it automates things without being in people's face, right? We think about AI sometimes a little bit too much like a big machine and somebody asking the question to the machine, what is the diagnosis? And then you get an answer back like the voice of God. It's really not the best way to think about AI in a field like healthcare. If you look at how other industries optimize AI, you often don't even notice it. Right? If you've been in your Tesla going at 60 miles an hour on a highway and you put it in autopilot mode, you're relying on machine learning, and you're relying on it for your life. Right? People do that more and more easily. Airplanes land because of machine learning tools and automation. So it's all around us. But when it comes to healthcare, we suddenly tend to gravitate towards the doctor making the decision, a life or death guided by AI. And it loses sight of the fact that some of the best applications of AI might be in the less sexy parts of healthcare. It could be billing and payments and simplifying those. It could be getting rid of the paperwork like prior authorizations and automating all of that, because the machine can read the medical record and automatically approve a prior authorization request. If the doctor is spending less time with the documentation, it's going to improve outcomes. You're going to have more time to look in the eye when the patient's sitting in front of you. So there are a lot of these use cases that are not controversial, that sometimes require data from across the healthcare system, and that can really produce tangible financial and clinical value. But they're not what you would call the cool cases people like to focus on.
Simon?
Yeah, no, I agree with that. I think we kind of know enough to be able to declare on AI uses in some of the things that the panels have been talking about today and I think tomorrow on dermatology, radiology, ophthalmology, a group at University College London, Moorfields Hospital and DeepMind have trained AI around retinal images with a 94% accuracy rate on diagnosing a variety of eye conditions. And that, I think, together with equivalents on dermatology and skin cancer recognition, we've talked a lot about imaging. The question there is not, is the content good enough? The question is, what's the route to diffusion? With all of the questions about how often you have to retrain, the scalability of the mechanisms, the extent to which narrow AI is a vertical bolt-on. And you've got a series of vertical bolt-ons, picking up actually what Governor Charlie Baker was saying earlier, from the point of view of the implementability inside semi-integrated health systems. That's really kind of the practical question there. But then looking out, I don't know whether it's 5, 10 years, we're always optimistic. There are some much bigger puzzles which actually we want AI to help solve for the health system. You know, by one estimate, 12 million Americans get a misdiagnosis, which produces harm for 6 million Americans each year. Comorbidity. Most of the guidelines, as we all know, that are written are single disease conditions written for otherwise healthy populations that often don't take account of the diversity of the patient mix that actually physicians and hospitals are going to be interacting with. If we can deal with some of that messy complexity of the real-world patient, that will be a huge gain for the quality and the efficiency of health services.
So I'm going to come back the other way now and ask what I hope to be a somewhat provocative question, which is, it turns out that your system across the pond and our system are a little different in the way they're organized. And picking up on what you just said, Simon, about the implementation and the complexities of implementation, successful implementation, would you say you would rather be in your current seat for implementing AI, or would you rather be over here based on what you know about the mess that's over here? Like, is it easier in a national health system where you actually sit on top of the entire delivery system for an entire country? Is that an advantage or a disadvantage in?
Well, some things, yeah. I mean, and by the way, I should declare I spent 10 years working over here before going back the other side of the pond to do my current job. And I've sort of previously said that actually Britain and America, the health systems have one thing in common in each country, which is in either country, to describe a good idea as having come from the other is enough to kill it stone dead. But that aside, the reality is the National Health Service is semi-integrated. So if you were sort of thinking of the typology, it's sort of somewhere between Partners and Kaiser, I guess. Thinking about some of the rivalries that exist even inside Partners, we're sort of somewhere between the two. There are some flexibilities that we have that the multi-payer US reimbursement environment doesn't give. So if we want to declare on shifts in radiology, if we want to eliminate probably a third of specialty outpatient, specialty office visits over the next 5 years, which is what we're aiming to do, we can kind of design a reimbursement system that holds people neutral financially to incentivize those clinical changes more easily than you can do in a kind of mixed Medicare fee-for-service, MA, commercial environment that happens over here. But having said that, frankly, I think a lot of the implementation challenges are very similar, which is we've got lots of interesting things beginning to fizz in different places. That's true in Britain as it is in the US. And now we've got to kind of decide what's the process for calling the play and then driving some of them to scale.
So Kris, what do you think? Would you rather be on his side of the pond, or?
Well, I would say for AI, the hairier the problem, the bigger the opportunity. So I would rather be here from that perspective because we are dealing with a massive problem in this country. By some accounts, over $1 trillion get wasted in the US healthcare system every year without better outcomes to show for it, right? That tells you the magnitude of the problem. And in the US, the healthcare system is not particularly consumer friendly. That's putting it mildly, because most of the healthcare system treats the consumer like a cog in the wheel that only becomes relevant when the bill shows up, and otherwise the system is engineered for everybody but the patient. So I do think that the challenge is bigger on this side of the pond in terms of scale and just general complexity. But some of the problems are actually very similar. As Simon pointed out, the lack of interoperability and the standardization of data across medical records is a problem that's similar, no matter where you go in the world, in fact. And the fact that the new set of technologies, particularly consumer-focused technologies that allow consumers to not only go direct to labs to get testing and results back, but also home health devices, I think that layer of technology is very democratizing. And it is universally useful all over the world. So bringing those kinds of inputs in and then being able to connect the dots across pharmacy and lab and other settings to be able to create AI that's more consumer friendly, I think that's something you can do anywhere in the world to great effect.
Yeah, and I would agree with that. I think the opportunities here are tremendous, and I would take the U.S. any day, because big problems create more innovation. And when we look in this country, you know, only 10% or so of patients get their care in academic medical centers, and the rest of patients are living in communities, big and small, getting their health care from a variety of places, and the opportunity to innovate with new AI solutions for home-based care, integrated care across employer, who are delivering a lot of health care value to their employees and dependents, to the pharmacy, to all of the other places that have been mentioned already. I think the opportunities are tremendous.
Great. I'm going to turn to some questions from our audience now. And we've got one. I think, Kris, this touched on something that you said. Maybe you could go into a little more detail about the question is, the lowest hanging fruit for physician-patient interactions is not necessarily diagnostics. It's integrating the medical record across providers and institutions and getting rid of the back office stuff like prior authorizations and other back office work. So you alluded to that in your opening comments. Could you go a step deeper and talk about how that creates value?
Sure. You can look at that problem from many different lenses. But maybe I'll take two. One is a physician's lens, and the other is a consumer lens. From a physician's perspective, all this added paperwork is sometimes entirely redundant, because the physician fills out the paperwork, and then somebody in the insurance company on the other side goes through the same paperwork, and they're essentially looking at the same rules, the same medical necessity criteria, and the same knowledge, and then deciding that, yes, something is required. That's how a prior authorization gets approved. Today, with machine learning and natural language processing, a lot of those charts can be read by a computer and can, with very high accuracy, be able to tell you 99% this prior auth is going to get approved. Now, of course, there are going to be some complicated cases where a human being needs to get involved. But if you can eliminate 8 out of 10 or 9 out of 10 of those prior authorization requests, the provider is going to be very happy, doctor is going to be happy, hospital's happy, consumers happy, because their claims get approved faster. From a consumer's lens, sort of shifting focus a little bit, the question was right on. It's about how well does the hospital and the doctor know me when I show up? It would be nice if I didn't have to fill out that piece of paper, that white sheet of paper and a pad every time I walk in, because, gosh, my mechanic knows more about my car than my doctor does when I walk in. How can we fix that? That's not per se an AI or a machine learning problem, but it is a connectivity problem, and it's one about data liquidity and making sure that the data needs to be, gets where it needs to be on time. So both of those aspects are not what you would consider the highfalutin uses of AI and machine learning, but they can save billions of dollars, which can then be put to better use, and it can free up a physician's time.
So if the U.S. is famous for its administrative complexity, I'd say the NHS has a reputation for having workforce problems. Can you say a word about the use of technology and the workforce, and maybe give the audience a little background about the workforce challenges that you're facing?
Yeah, absolutely. So picking up your point, one of the great gifts that technology could give would be to free up time for health professionals. And let's face it, the kind of generation of EMRs that were invested in off the back of the stimulus funding a decade or so ago were kind of the opposite of that. And somebody said earlier, actually sort of algorithmic-based kind of clicking, control F9, control F9, control F9, going through all of the ludicrous prompts that are just kind of overwhelming people to actually be able to get to the clinical encounter. That is very unsatisfying in terms of the practice of medicine or nursing. So anything that can take that away, if we can get that right for this generation, will be a huge gain. And particularly for some of the key kind of pressure points we've got around diagnostics, around there's enough work to go around, in other words. I don't think anybody should be worried about how jobs will be reshaped over time. And in both countries, frankly, the productivity of the health sector is hugely important for the welfare of the nation. In this case, it's what, $3.7 trillion here in the US. It's a rather more modest amount on the other side of the Atlantic, but nevertheless, in both countries, health systems are taking resources that at the margin could be used for wonderful things if we can free up time and do more with what we've got.
So that's great. Do you want to say a little bit more about that, where you are with your group and how you look at value creation in technology?
Sure. We actually have created at the American Heart Association a value in healthcare roundtable that has leading executives across every aspect of the care delivery system, including patients. And we're looking at modeling solutions, many of which are technology-based solutions that can assure value is delivered without bias in AI solutions to patients in various settings. So we're looking at things ranging from how clinical care is delivered in large healthcare systems to rural health, which is a very large focus. We're about to publish a presidential advisory at the AHA on rural health, and we'll call out many of these opportunities for technology to really improve care delivery for people in rural systems. And I think Dr. Schwam from the Mass General mentioned this morning in a session that he was in the importance really of making sure that AI solutions that are created can help enable rural healthcare systems to be sufficient and productive versus it replacing a rural healthcare system. So that's certainly a point that we would agree with at the AHA. We're looking at clinical trial design right now. I might mention, not connected to our value in healthcare work, but in our work to really think about new ways to inspire patients and individuals to participate in clinical trials where AI ultimately will become important. We've launched a new initiative with Verily called Research Goes Red, which is an extension of Go Red for Women. For those of you who follow Go Red for Women, it is our campaign to help women understand that heart disease is their greatest health threat. And what we know is that women are underdiagnosed, their symptoms are underrepresented, they are not included to the same proportion as white men are in clinical trials and in other aspects of medicine delivery. And we also know that treatments that are given to women have been developed through trials that have been conducted for men. And to give you a sense of the hope that we have for this, in 4 weeks, we have had over 56,000 women. This is a technology-based recruitment. 56,000 women come for more information to the AHA's Research Goes Red with Project Baseline. We've had over 11,000 women register and just under 5,000 fill out the complete consent to be a research participant. And here we intend to gather all kinds of information, survey information, wearable information, EHR information, and with Verily's Baseline platform, we'll be creating this holistic approach and on behalf of women, taking the bias out of the system in the development of Research Goes Red and certainly in what comes out at the other end.
So let's, Nancy, I'm going to push you a little bit on that and say, so what are your levers for, I was going to choose the word forcing, I don't mean the word forcing, but getting your members, which are, it's the largest healthcare volunteer organization, to more rapidly adopt precisely the kinds of things that are going to produce those benefits.
Yeah.
But
we have to push on our system, which we're doing right now, and it starts at the very beginning. You know, the HA is unique for those of you who don't know. We're a scientific organization, 36,000 scientific volunteers and members, you know, the second largest funder of research in the U.S. outside of the NIH for cardiovascular and neurological research, all the way to the 35.5 million volunteers and supporters and communities. So we think across the spectrum all the way, it's the way we work. And we're trying to push every aspect of the system, you know, from how are we creating science. You'll hear from Dr. McCrae, I know, in the next session, and we're pushing the system hard on one brave idea to try to use these new technologies and AI approaches to get, you know, solutions created more rapidly. When it comes to how we write guidelines, we understand that guidelines can be written more quickly, the information can be synthesized. You know, we delivered the high blood pressure guidelines a year or so ago, and 110 million people woke up the next day having elevated blood pressure that didn't have it the day before. And the healthcare system wasn't ready to know how to deal with that on behalf of patients. And so we've got to fix that. And we're pushing that issue in how we create, how we develop, how we disseminate, and how we train the healthcare workforce, and how we enable patients to be their own best health advocate. Because at the end of the day, we believe the two have to meet each other.
What about you, Simon? You're the chief executive of the entire delivery system. Can you just tell people to adopt technology? And that's
no, no. I mean, yes, we've got 1.3 million clinicians. We've got 50,000 scientists working across the National Health Service. But look, the practice of medicine has grown up in all industrialized countries as a pretty decentralized process involving magic between individual clinicians and individual patients that have then become teams and then teams of teams. And now the question is, how do you get that broader standardization on the things we can? And I mean, in a sense, the discussion you were just pointing to around guidelines, I mean, it's a really interesting question as to whether the clinical guideline will end up being an obsolete technology at some point in the fairly foreseeable future, because so many of them are designed for the median patient or for 3 or 4 flavors of the patient. And our hope collectively is to move way beyond that, tempered by the reality of what we just heard from the last panel, which is we still can't machine read PDFs. But the fact is we've got more than 2.5 million English language research publications each year, and the ability for individual clinicians or systems to synthesize those in their own day-to-day clinical practice is obviously highly constrained. So as you sort of think about the way the epistemology, if you like, of medicine has developed, I mean, we have moved to the the RCT, to the systematic review as a sort of supplement to expert opinion, and what we're really now trying to do is kind of move to something beyond that. And for a lot of conditions, that's going to make a hell of a difference.
If I could just push on
Sure.
that, though, I would say that yes to most of what you've said, but at the end of the day, I think a patient who is sitting there would want to know and understand that real people, have looked at the evidence, have understood the issues, and have given an expert opinion on the value to the broad population of a recommendation. I think from certainly my point of view, and I believe I speak on behalf of my organization, the thought that computer-generated algorithms, that people and doctors are just, searching for online and saying, okay, all of you people look the same, so here's the treatment for you, that would be a scary day, because what we haven't talked about here are the other things that impact a person's health and well-being, the things outside of the system, their education level, their income level, their access to health and healthcare, their access to healthy foods and places to exercise, the social determinants of health. Very important. And when we're thinking about the future of guideline development and more individualized or personalized guidelines, those factors must come into play. And I think no artificial intelligence powered technology will ever be able to replace a person making expert opinion, and certainly we hope never be able to replace a person looking in the eye of a patient who all they want, especially at the time of a terrible diagnosis, is their healthcare provider to hold their hand and tell them that life will be okay, or that they're there to help them.
I think Simon wants to come back.
Well, yeah,
I'm sure he does.
No, I think that's a fascinating discussion, because I think you're absolutely right about the fundamental importance of humanity and the human contact and the healing relationship that exists between the patient and the clinician. But is it perhaps the case as well, though, that if you take a couple of practical examples, right now, if you're a woman diagnosed with metastatic breast cancer, your ability to get good advice from your oncologist as to what your personalized prognosis looks like, or what your likely expectation of side effects from the particular therapy you're given, I mean, that's not available from the marketing authorization or indeed the standardized guideline. So it should be possible to kind of empower the quality of those conversations. But I want to push it even further than that and say, to the extent that we've got explainability of what's coming off AI, then you can see that the clinician is ultimately making that judgment as an interpreter of it or providing a second opinion to it. But once we've moved beyond explainability for some of the diagnostic recommendations, what are we really saying about the responsibility of the individual clinician in that situation? And I just wonder whether there's not a parallel with the debate that's been happening around social media as to whether social media companies are just a platform or whether they're actually publishers with some responsibility for content. And I suspect it won't be too long before we're actually having the discussion as to whether the AI equivalent is as a publisher with the responsibility for the decision content, not just as a decision prompt for the clinician in front of the patient. Discuss.
So I want to, I think there's general agreement here about the value that can be created through AI. Let's talk a little bit about the barriers, and then I want to finish by talking about how much value. And so maybe Kris, could you say a word about the balancing issues of privacy and the requirement for access to data to make AI work? And are the privacy issues associated with access with data going to moderate the value that can be created through AI, or are we going to find a way through that?
Happy to weigh in on that. It's privacy in healthcare is certainly a big topic and has been actually for a long time. And for those of us who have been involved with healthcare data privacy and liquidity and use of data, this is not new. What is new, however, is the public's general awareness of data. And we have Facebook and Google and others to thank for that. There's all of a sudden, there's a renewed interest from a consumer privacy perspective in all kinds of data. What we need to do is make sure that we don't conflate or look at all data from the same lens. Healthcare data is not regulated today in the same way like Facebook's data is regulated. Now, the healthcare data has been highly regulated for a long time. In fact, I would argue the problem with data in healthcare is that it's too stuck in silos. If we ever want to get to value-based healthcare, we need to have data flowing. You need to be able to measure value. You need to be able to measure quality. And no industry has been able to do that without making the data flow. And the data doesn't flow in healthcare because it's been, I would argue, maybe over-regulated with an interest in protecting privacy, which is perfectly good. And I have an interest in my data privacy like everyone else. But at some point, it begins to hurt us as individuals because that data is not available where I need it to be at the time I need it to be. So as a healthcare system, actually, we are entirely too constipated in the way we look at data and allow data to be used. So we cannot talk about Facebook's use of data and healthcare data in the same way. Healthcare data is regulated. We can actually derive most, if not all, of the value that we're talking about here through the use of data and AI in healthcare while completely preserving patient privacy, consent, and actually doing it the right way because we've anchored, the healthcare industry is anchored in that mindset, which is patient privacy, consent, HIPAA regulations, and frankly, locking everything down. It's easier to go from that to freeing things up for the right uses rather than starting with a free-for-all kind of system that you see with data on the internet and other social media and trying to put that cat back in the bag. That's much harder to do. So I'm very optimistic about the use of data in healthcare, and I think we have a chance to do it right while preserving privacy.
Kris, great job connecting this discussion to the CT colonography discussion this morning. So Simon, I've heard stories about issues with privacy and data and the public's view of them. How are you looking at this?
I think there's a paradox, which is that on the one hand, most patients expect there to be more data sharing between clinical teams and across the health system than actually occurs right now. It's exactly as the other panel members have said, and having to tell your story on multiple occasions, and pieces of information not being connected, and occasionally having to do duplicate tests and exams and all the rest of it. That's a care coordination problem of which illiquid data is kind of one of the root causes. So in that sense, people are surprised we haven't got more of it. On the other hand, when we then start talking about how to raise our game, trust is really at the heart of the equation. And trust boils down partly to the question of identifiable, and if so, consented information. But as we all know, identifiable versus anonymized is not a binary distinction, particularly given where the world is headed. So then it comes down to a question of who is sharing data, how are they doing it, and for what purpose? And being clear about those three questions, I think, is at the heart of winning the trust argument.
Great.
Well said.
So I'm going to ask a final question now, and I'm going to ask you to go out on a limb, each of you. So both the US and England are facing what I would call an unsustainable problem. Here in the US, the costs are unsustainable. And in the UK, I think you've got the workforce and the budgetary issues place a similar unsustainability in the future through any set of projections. And the question is, will we innovate our way out of this unsustainability of our healthcare systems through the kind of tech that is highlighted at this conference today? Will that get us out of this conundrum? So I'll start with you, Nancy.
I think as long as we don't forget who is the ultimate beneficiary of this work, and it's the patient, and if we're designing things that improve workflow, which I agree with you is, an undervalued but highly desirable thing that could free up time for health and healthcare providers, I'm quite optimistic that all of this technology will be an amazing way. If you go forward 10 years from now and you think about, just to the point you were raising a moment ago, Simon, about privacy, whose data is this anyway? If there's a democratization of data, and this is one of the things we're trying to press on with Research Goes Red. Let's put these women in control of their data and let them tell us how much and how little are they willing to share and for what purposes are they willing to consent. If you make a bet on democratization and putting people in charge of their own data and the power of the technologies to create new systems to improve workflow and to improve collection and integration of data, I think we'll see a tremendous benefit in the future.
Kris?
So I'd point to two things. If you look at, people, I forget who said this, but people often overestimate what you can do in 1 year and grossly underestimate what you can do in 10 years. I think there's going to be something similar that plays out here. You asked about innovation. I don't see any other way that we're going to dig ourselves out of this problem. We have to innovate out of it. And I would simply point to the fact that look at the amount of waste, at least in this country, that we have in healthcare. $1 trillion, almost a third of all the money we spend, is wasted. And one way to get your arms around that and try to control that and take it down is to empower the consumer to be a truly discerning customer. And that is something that is somewhat novel to our healthcare system. We've never had a consumer that's empowered. And some people will say, well, consumers are not capable. Healthcare is too complicated, and consumers are not capable of making the decisions because they're all complicated medical decisions, and someone's got to tell them what to do. Well, that was true in banking, and it's true in many other industries too. But when there's a need Technology rises to the occasion with empowering tools, and I think that's going to happen with healthcare as well. There will be more empowering tools that simplify a lot of the complexity of healthcare to help consumers make smarter decisions. So that's one aspect of it. The other aspect is if you look at the disease burden, we complain about the fact that there isn't a cure for Alzheimer's, there isn't a cure for Parkinson's, and an average drug takes $2 billion and 10, 15 years to get to market. To some extent, we have ourselves to blame for that slow pace of progress because we have wrapped ourselves with data silos and trapped all the data in a way that does not expose its true value to the ecosystem. So if you believe that at some time, at some day, we're going to have a cure for these diseases, where is it going to come from? It's most likely going to come from a combination of data sets. It's going to be molecular data that's coming from the growing array of sequenced data, molecular data. It's going to be combined with a lot of clinical data that's now being captured. It's going to get cross-correlated with home health data, with devices that we're all wearing. That's where the signals are going to come from. And if you're lucky, that kind of a therapy or a new treatment or cure might come by in the next 5 years, right? If you're unlucky, it might be another 25 years before we have a cure for Alzheimer's. And you can just imagine the cost to the healthcare system between having a cure and not having a cure, right? So I do think we are going to innovate our way out of this problem. We have to. But we have to keep in mind that data and particularly new empowering technologies like AI have a crucial role to play, and we've got to treat those well. We've got to take care of and invest in those technologies.
Simon, you get the last word.
Well, so I agree. I think there's a huge efficiency opportunity. The interesting question is whether it actually speeds discovery and makes discovery more affordable. And I think we had a somewhat, a very pragmatic answer to that question from the last panel on real-world evidence. But the fact is we do need that, and we need that for all kinds of new reasons. So, I mean, in the NHS, in December, we just sequenced our 100,000th whole genome. We're going to make that 1 million whole genomes over the course of the next 5 years. That and the other data that are going to become available to us, unless we've got a massive increase in computational power to generate the insights we need, then we're just not going to get the payoff from some of those other investments that we are making. So we need that, but I would say, finally, we've also got to be socially intentional about how we deploy some of these new technologies. In both the US and the UK, we have significant issues with health disparities, well documented. There was the famous JAMA piece, I think, recently on melanoma and on white skin versus black skin and the less detectability despite the fact that although the prevalence amongst African Americans of melanoma is lower, the mortality is higher because of late diagnosis. So we actually need all of the brilliant people who are working in this area to be intentionally thinking about how some of the problems to be solved can be problems that are problems of disparities, not just problems of discovery at the frontier. And if we do that, then we will win the public argument that Governor Baker was talking about earlier as to the vital importance of AI in improving healthcare for all.
That's a great note to finish on. I would like everyone to join me in thanking this terrific panel, and thank you very much.